Hello and welcome back everyone. Today we are going to discuss the new topic, that is anti-ulcer agents, which are the drugs acting on gastrointestinal tract. So let us start our discussion. What are peptic ulcers? Peptic ulcers are painful sores that develop in the lining of the stomach or duodenum when the protective mucosal barrier is compromised by excessive gastric acid and digestive enzymes. The common causes of the peptic ulcers includes Helicobacter pylori bacterial infection, which is the main cause of the peptic ulcer. Long-term use of non-steroidal anti-inflammatory drugs is another cause. Excessive acid production in GIT and stress and lifestyle factors are among the common causes of peptic ulcers. Typical symptoms of the ulcers includes burning epigastric pain, which often worse at night. Nausea, indigestion and bloating are some other typical symptoms of peptic ulcers. While in severe cases, there may be chances of gastrointestinal bleeding. So let us discuss the physiology of gastric acid secretion. Understanding how the stomach produces acid is essential to comprehending how anti-ulcer medication works. Parietal cells in the gastric mucosa are the primary acid secreting cells which are regulated by multiple pathways, such as first pathway is receptor activation. Three key receptors stimulate the parietal cells: H2 receptors, muscarinic M3 receptors, and CCK2 receptors. Histamine stimulates H2 receptor, acetylcholine stimulates M3 receptor, while gastrin stimulates CCK2 receptor. And by activating these receptors, there is increased in the secretion of gastric acid in stomach. Second pathway is by means of proton pump. The hydrogen potassium ATPase enzyme exchanges hydrogen ions for potassium, creating the acidic environment. And by this means, proton pumps increases the acid secretion in stomach. Mucosal defense. The protective mucus layer and bicarbonate secretion balance the aggressive acid factors in gastrointestinal tract. So gastric acid secretion is controlled by these pathways. Now, modern anti-ulcer therapy employs multiple approaches to heal the ulcers and prevent the recurrence of the ulcer. Each strategy targets a different aspect of ulcer pathophysiology. First approach is to reduce acid secretion in stomach. Suppress gastric acid production at the cellular level using receptor blockers or proton pump inhibitors is one of the important strategy of using anti-ulcer agents. Neutralizing existing acid. Chemically neutralize stomach acid to provide rapid symptomatic relief and raise the pH. For this purpose, we use antacids. Third approach is to protect mucosal lining, create physical barriers and enhance the natural protective mechanisms to promote healing. And finally, eradicate H. pylori. Use combination of antibiotic therapy to eliminate bacterial infection and prevent the recurrence of peptic ulcer. So such different strategies can be used to protect from ulcers. Now let us discuss various drugs which are available as anti-ulcer agents. So first class is H2 receptor antagonist or H2 blockers, which blocks the H2 receptors competitively. These H2 blockers competitively block histamine H2 receptors on gastric parietal cells, preventing histamine stimulated acid secretion. This reduces both basal and stimulated gastric acid output. Common drugs available are cimetidine, ranitidine, famotidine, and roxetidine. These drugs are used in the treatment of duodenal and gastric ulcers, gastroesophageal reflux disease, Zollinger-Ellison syndrome, and also for the prevention of stress ulcers. Generally, these drugs are well tolerated but may cause some side effects like diarrhea and dizziness. Cimetidine can cause gynecomastia due to anti-androgen effects, and it has multiple drug interactions. Second category of drugs which can be used as anti-ulcer agents are proton pump inhibitors or PPIs. For example, omeprazole, lansoprazole, pantoprazole. These drugs irreversibly inhibit the hydrogen potassium ATPase proton pump in the parietal cells, providing profound and long-lasting acid suspension. These are the most effective acid reducing agent available. This can be used as a first line agents for peptic ulcers, GERD, Barrett's esophagus, Zollinger-Ellison syndrome, an essential component of H. pylori eradication therapy. Their adverse effects include nausea, increased infection of like pneumonia, some malabsorption of nutrients like malabsorption of vitamin B12, magnesium, calcium, etc. and rebound acid hypersecretion upon discontinuation is also observed. Next class of drugs which can be used are antacids, which neutralizes the gastric acid in stomach. Antacids provide rapid symptomatic relief by chemically neutralizing the stomach acid, rising gastric pH, and reducing pepsin activity. They are classified based on systemic absorption into two classes: systemic antacids and non-systemic antacids. Systemic antacids includes sodium bicarbonate, which has rapid onset but short duration of action. Since it is systemic antacid, there is risk of metabolic alkalosis and sodium overload with prolonged use. Second class of antacids is non-systemic antacids, which may be magnesium containing salts, aluminum containing salts, or calcium containing salts. Magnesium containing antacids includes magnesium hydroxide, which effective neutralize the HCl with laxative effect. Aluminum salts includes examples like aluminum hydroxide gel, long acting with constipating effect. So to counteract this constipating effect of aluminum hydroxide is given with magnesium hydroxide. Third one is calcium containing antacids like calcium carbonate. It is a potent acid neutralizer with supplemental calcium benefit, but there is risk of rebound acid secretion. Antacids are often given in combination in commercial preparations to optimize the efficacy while minimizing the side effects like diarrhea or constipation. Next class of drugs are mucosal protectants and prostaglandin analogs. Sucralfate. It forms a viscous paste-like protective barrier that adheres to the ulcer craters, shielding them from acid and pepsin, while promoting healing through growth factor stimulation. There is minimal systemic absorption. It requires acidic environment and shows few side effects. Second example is colloidal bismuth, which protects the gastric mucosa through multiple mechanisms, like it forms protective coating, stimulate mucus and bicarbonate secretion, and exhibits mild antibacterial activity against H. pylori. Black stool is normal while using colloidal bismuth. It has anti-H. pylori properties and used in quadruple therapy. Next example is misoprostol, synthetic prostaglandin E1 analog that increases the mucus and bicarbonate secretion while reducing acid production. It also prevents the ulcers induced by the use of non-steroidal anti-inflammatory drugs. It works by increasing the mucosal defense, reducing the gastric acid, and it is contraindicated in pregnancy. Next class or next therapy is anti-Helicobacter pylori therapy. Helicobacter pylori infection is responsible for majority of the peptic ulcers. Successful eradication dramatically reduces the ulcer recurrence rates from about 60 to 70% to less than 5%. The various approaches includes triple therapy for 7 to 14 days, in which proton pump inhibitors with clarithromycin and amoxicillin and metronidazole is given. Quadruple therapy from 10 to 14 days, where proton pump inhibitor bismuth with tetracycline and metronidazole is given. Sequential therapy constitutes PPI, amoxicillin, then PPI plus clarithromycin plus metronidazole for next 5 days. That means in sequential therapy, PPI plus amoxicillin are given for 5 days, then PPI plus clarithromycin plus metronidazole for 5 days. And finally, confirmation testing. Verify the eradication in 4+ weeks after therapy completion using urea breath test or stool antigen method. So finally, we can summarize all this topic that anti-ulcer agents have transferred peptic ulcer disease from a chronic debilitating condition requiring surgery to a medical manageable disease with excellent outcomes. Drug selection depends on various factors like ulcer etiology, severity of the disease, the infection, the use of non-steroidal anti-inflammatory drugs, and some individual patient factors like age. Ongoing research focuses on novel mucosal protective agents, acid pump antagonists, and targeted therapies with enhanced efficacy and minimum side effects. So, key takeaways from this session are: proton pump inhibitors are the most potent acid suppressors and first line drugs for most of the peptic ulcers. H2 blockers provides effective acid reduction with excellent safety profiles. Helicobacter pylori eradication is essential for preventing ulcer recurrence, while combination therapy is often more effective than monotherapy, and early diagnosis, appropriate treatment selection, and patient adherence are critical for optimal healing and preventing the complications of peptic ulcer. So that's all about these anti-ulcer agents. Thank you.